our Masters in Public Health programme. We have multiple routes in our Masters in Public Health. If you want to learn any more about our MPH programme or the diploma and certificate routes, there's a link on the screen, and I'll add these links to the chat box later on. There's also information about ScHARR's short courses at the link you can see on the screen. We've started doing our short course series online, and we have quite a few online courses planned for the first half of 2021. So if you want more information about those, again, I'll put the link in the chat box. And you can also find us on Facebook at facebook.com/ScHARR Sheffield. Some of the online short courses that we've got coming up you can see on the screen here. Developing Complex Interventions to Improve Health is our next one. It's today. A waiting list currently in operation, I see. Fair enough. You can join the wait list for that one. Andy will be running an Introduction to Social Media to Communicate Research on 27th of April and 28th of April. Andy is the organiser of this webinar series. And then the next one after that is Introduction to Starter. So, like I say, I'll put the link in the chat box if you want to investigate more about our short courses. The next one in the webinar series is coming up in April. Our next webinar is with Dr. Fiona Campbell, who's a research fellow in ScHARR, and Elena Sheldon, who's a research assistant. And their presentation is going to be about the factors associated with student mental health, reviewing the evidence. So again, we'll put the link in the chat later, but if you want to sign up for our April webinar, that's the topic that we'll be looking at next. So today we're joined by Professor Stephen Julious, who's going to be talking about case studies and exemplars of efficient study designs in clinical trials. Stephen has obviously a background in maths and statistics. He has a BSc in maths statistics and operational research from University of Manchester Institute of Science and Technology, an MSc in biometry from the University of Reading, and a PhD from University College London. His main research interests are in all aspects of clinical trials, but with a particular focus on clinical trial design and the development of applied methods related to clinical trials and adaptive trial designs. As I've said earlier, Stephen teaches statistics here at ScHARR on our MPH programme. We have modules on both basic and advanced statistics, so he'll be familiar to anyone who's studied our MPH. I know we often get former students who come along to these webinars. So now I'm going to hand over to Stephen. I know you'll need to switch over to screen share to show us your slides, but feel free to do that now, Stephen.
Okay, got to be honest. I was actually working. Hold on. But where is, now you got me now. All right, there we are. Add it all up, share files, and as a sign of age, though, actually, Claire was just actually giving my background. I went to UMIST, and that university doesn't exist anymore. And I did MSc in biometry, and that MSc doesn't exist anymore. So I've jinxed a lot of education establishments where I went to my junior school doesn't exist. My secondary school burnt down. My further education college doesn't exist. My university doesn't exist, and my master's degree doesn't exist. So anyway, I accept bribes for people who want me to stay at ScHARR because it might not exist much after I leave. But what I've got here is it's a narrative of a series of case studies and examples. I've just tied it into a rough narrative on efficient designs I've had experience of over time, and so yeah, so it's a very applied talk. There's no formally in here, and hopefully it will give people an idea of what efficient designs are and when they can be applied. Before, usually I finish with acknowledgements, but I like to start with acknowledgements, especially as this is a lot of students on the line. I'd like to thank these people: Munya, Julia, Laura, Fung, Ben, Abigail, Laura, and Amy. These were different times PhD students, master's students, and research attachment students who have worked with me on my research over time. And I'll be quoting some. If I don't quote them, it'll be an amiss of me. But a lot of the work is based on the work I work with them on, while I've been here in Sheffield. So what we're going to do is start off with a definition of my personal definition of what an efficient design is. Then I'll go through the different case studies. I'll talk about Precedent, which was a study I worked on, Rat Pack, which was a study we had in Sheffield here, and I worked on also. I'll talk about other types of adaptive designs and future work, and hopefully there will be time at the end for some discussions and some conclusions. So what is an efficient design? I personally think it's just an umbrella term for smarter ways of doing things. People talk, especially the funders, talk about efficient designs, and basically, as the name implies, is actually can we do it better? So it's efficient. It doesn't need to even be saving money, so you could be saving time, but doing things smarter to get things done as efficiently as possible. That could be using routine data. It's very expensive to collect data, so if you can actually use the data that you collect routinely while a patient is being treated, that will actually speed things up. Using early data instead of late data to make decisions, and I'll give an example of that. Being adaptive, and I'll describe what an adaptive design is, and even just simple things like in the cycling in the UK, they talk about if you make lots of small changes, those small changes add up to quite large improvements. So this is an example of using routine data, but all I need to do is give some background into what the problem was. So in the UK, well, actually it's everywhere, but actually predominantly, and this is actually in the UK, I'm giving an example here. When children return back to school, there is a pronounced increase in asthma episodes, and it's associated with more population mixing. So there's more. So basically, over the summer holidays, the children are hanging around with far fewer children. Then they go back to school, and suddenly every infection that's going around hits them. And so this is an example here. I got Scottish and English data, and so admissions for asthma increased 2 weeks earlier in Scotland and England. I got Doncaster, Aberdeen data here. The reason why that is important is actually schools go back to children return to school 2 weeks earlier in Scotland. So if they go back, it's like an experiment I've used quite a few times. The fact that children, my research interest is actually around the return to school, because actually I go by the maxims of what you can predict, you can prevent, and this is a predictable occurrence that happens every year, and can we work to prevent this? And in Scotland, the effect of school happens 2 weeks earlier than in England. So I've got Doncaster data and Aberdeen data here. This is actually data I got from a data database called the Clinical Practice Research Data Link, and I got 100,000 patient records from there. I got 100,000 cases, 100,000 controls, and so the healthy controls were people age sex matched with people with asthma. And what we found, what I was trying to do here, was actually predict from the people with asthma, predict the cases of people with asthma from the healthy controls. And so the return back to school it causes a 15% increase in medical contacts amongst children without asthma. So this viral challenge brings on various things like the flu and various symptoms. But for children with asthma, this bump here is telling like the increase is bigger and bigger than expected than you would think compared to a healthy population. 30% of children with asthma will go and see their doctor after the return to school. And what caused this, and this is CPRD data as well, is actually so September is when you get the biggest challenge. This is so when you have asthma, there's two types of inhaler you can have. You can have a reliever and a preventer. Now the reliever, if you see anyone with asthma, is a blue inhaler they puff on when they get a bit wheezy. And they have preventer medication. And children stop taking their medication. A lot of children stop taking their medication in August. This is data from England. But they stop taking it in August just as they're about to get the biggest challenge of the year, which is going back to school. So this was the motivation for my study, for my research, which was called Pleasant. And so I designed a study called Preventing and Lessening Exacerbations of Asthma in School-Aged Children Associated with a New Term. So it's had quite a nice, which came first, the acronym or the title, you might ask yourself. This was designed by the study children. So for a period of time, I was a pleasant statistician. I was only pleasant for 1 day a week. The rest of the day of the week, you didn't really want to know me. But I was pleasant for a period of time. And it was quite a simple study. It was a NHS delivered public health intervention. In fact, what we just did, we sent a letter out, the GP sent a letter out to children, parents of children, telling them about the importance of taking their medication and saying that, can you please continue? You're just about to go back to school and we found this is a difficult time. Because of my experience of collecting data with CPRD, I decided to use CPRD for the data collection here. And by doing this, 140 GP practices, I'd have had to recruit 140 GP practices. I'd have had to send in someone on the traditional side into them individually, go and collect the data from each of those practices, and then do all the data handling. I costed at the time that it was approaching £1 million I saved by using routine data. I don't get an exact figure because it's hard to tell, but it was a lot of money because with CPRD, there are issues with the CPRD, which I'll touch on later on. They go in and once a month collect the data, and it's routine data, and they just go and collect it every month. And that's actually saved a lot of money compared to a traditional design where we would go in and collect the data from the individual practices. There were challenges. You don't have to see this. To code this data, this is routine data, and it was collected not for research purposes. And so it was fit for purpose. It was fit for the purpose of which the people in the general practitioners were collecting the data, which was to manage the of the people's children. But there were challenges in that they weren't coding it like a trial. And you can just see, and this is actually one of the many algorithms that we set up, and we had to have assumptions. We had an adjudication panel, an independent GP adjudication panel, and it wasn't as easy as a trial to collect the data. The CPRD was designed for epidemiology studies, not for clinical trials, and so it presented challenges. And routine data also presents challenges because actually when you do a trial, it's coded, it's harmonized, and you get everyone to record things in the same way. Well, this you've got 140 GP practices, they're coding it in 40 different ways. But also we were following data up over time. And when you follow that routine data over time, things change with that as well. I knew things change with asthma over time. But this is an example of another piece of research which I worked on, and it's actually how routine data. This is actually routine data. This is actually the rate of sudden infant death in the UK over time. So this is actually 1991. Britain had a back to sleep campaign, and it almost overnight the rate of sudden infant death almost like halved overnight. But then in the noughties, which I was looking at, there'd been a pronounced 4 again. But this is one of the issues of using routine data, is that the 4 wasn't pronounced. There was another coding that had come in, and people weren't just coding cot death. There was another type of death which had just been introduced called unascertained. And so it wasn't that cot death was falling, it was actually that people were classifying things differently. And so it's brilliant to use routine data. It can save you a lot of money, but you just need to be aware when you're doing it, because actually clinical practice changes over time. So even like some definitions of a clinical condition will change over time. So the incidence and prevalence of that condition will change just because someone issues a new guideline. And this is an example here where a diagnosis changed over time as medical practice changed. So the pluses, actually, usually when I give the mention pleasant, people don't hear me beyond how much money it saved. And they think, well, sort all the other things out down the line. But there are challenges in doing this. So another type of efficient design is to do a special type of design called an adaptive design. And this slide here gives an illustration of what an adaptive design is. Now, a traditional clinical trial, you start your study, you recruit all your patients, and then sometime in the future, you stop your study and you analyze them. And I always say, well, when NASA launches a rocket to Mars, it doesn't point it at Mars with the hope that in 2 years' time it will hit it. It will actually alter the course and make decisions as it goes. So it's the same principle with clinical trials. So here, this is actually, if you notice the clinical trials, we've got to keep our significance level, our type 1 error, restricted to 5%. But here is like the simplest type of design we've got. We've got a look at the data. We make a decision whether to stay or should we go. And then based on that decision, we actually collect a second group of people, and then we make a final look. So it's just the simplest design you can have, where you just take one look at the data. Oh, got to jump 2 slides. Oh, now I'm going to jump 2 slides again, because there is a bit of a time lag. You click, and it takes about half a second. That's it. And the motivation for this was a study. We didn't know the detail. And actually, I had 3 estimates of the variability, 14, 27, and 39. And if I went for 14, the sample size was around 12 per arm. And if I went for 39, actually the sample size was 60 per arm. And so we were sitting there scratching our heads, because that's a 3-fold difference in the sample size. But actually what had happened where I was working at the time, they'd just done a study where they went for the smallest sample size possible, and then the true variance was actually the big variance, and the study failed. So I was actually pushing an open door at the time to propose an adaptive design. And what we did, we designed the study, and then was going to look based on 27, and then was going to recruit 30 people, and then recruit 30 more people, and then the 30 more people was designed around the variance of 39%. What we didn't want to do was do a study and fail around something which we could have controlled. So this is it. We did an interim analysis. We recruited 30 people, and based on that 30 people, we made a decision whether to stay or go. And then the final study could have had up to 60 people in the study. And then schematically, this is what I've actually just put all the numbers on. So when I was actually, this comes on a long time ago, when I was trying to convince people to do this adaptive design, I had lots of slides saying how brilliant it was, and it was a work of genius and things like that. This was actually about as simpler an adaptive design as you could do. And there's like various things that was in our favour. We control recruitment. It was an early phase trial, and we invited people in and we dosed them when we wanted to. So we brought, literally we would treat 30 people on the same day. And so we'd invite them in, bring them in, 30 people, and that made like planning for the analysis and everything all quite straightforward. It is quite a challenge if recruitment is still happening, and this is actually happens more often. I propose adaptive designs quite often, and I always say it's the logistics, not the statistics, that determine if an adaptive design is possible. I had a study a while ago, and the primary outcome was at 2 years, and it was just crying out to be adaptive. There was too many uncertainties in the study that we was all uncomfortable doing the study because of the uncertainties in the design in the study. In fact, you have this paradox when you do a study, in that often there is a lot of uncertainty when you design it. You would love to have a beautifully designed study in the same population to help you design your current study. But the reason why you're doing your current study is actually there isn't a beautifully designed study already, and that's why you're doing your study. So you get yourself caught in this Gordian knot. You've got suboptimal estimates, and that's why you're doing the study, but you're very uncomfortable about doing the study because there's not a nice study to base your study on. So in that study where the primary outcome was at 2 years, we could have proposed an interim analysis, but what would have happened, we'd have actually finished recruiting all the patients before we'd actually got round to do it. And so logistically, it just was not possible. There are options when you're doing this. You could use a thing called a surrogate endpoint, which is not the primary outcome of interest, but another outcome which predicts the primary outcome, and that would assist you in your design. In this study, we was actually using the same outcome for the analysis as we was at the end, but often that is not the case. So if you haven't got the same outcome, and that was an example I gave earlier, 2 years was the primary time point. We were thinking of 3 months and 6 months instead, and that brings in challenges. One of the main challenges is if you are using that surrogate, how can you predict the response? You are actually bringing in risk into your study. So that study, as almost like an introduction to adaptive designs, it was we controlled recruitment. We had the same outcome in the interim as the definitive study, and that was actually pretty minimal risk. Often you're not controlling recruitment. There's a speed to get the decisions done as quickly as possible because recruitment is still happening, and then the outcome that you want is not often possible to collect, which actually can rule out actually doing the study, or you choose an alternative design. So this was actually the thing about using an earlier time point, was the subject of a PhD student, Fung's PhD, and what he was looking at. So when you do early phase research, you just don't go in and give everyone the highest doses. They start off doing a design like this, where they do give some people a low dose, and if that low dose is safe and tolerable, they give the next dose up, and then the next dose up. So they're making a series of interim decisions. It's not adaptive design per se, although it can be, because they can alter the doses that they decided to do. But it's what I call a learning study, not a confirming study. It's about learning about what is the dose effect of the study. So this is actually schematically what it looks like. You've got the minimum effective dose, you've got the maximum effective dose. Between those 2 points is what we call the efficacy window. And then between the maximum effective dose and the dose up here is what we call the safety window. And you want to have a dose in between these 2 points and as far away from a dose which is could cause serious adverse events. And this is what you're doing in these studies. You're trying to identify what your efficacy window is. So what Fung was thinking, and in this design what we was thinking about, was actually the primary time point was day 56. So you collect a cohort, you follow them out to day 56, you make a decision, and then you start the next cohort. And what we was looking at was whether we could actually reduce the time of when we looked at the data to day 14. So you can see here the 3 lines are day 84, and you see the biggest response at day 84, day 56, and you see the smallest response at day 14. But we could actually predict the data at day 56 from the data at day 14. So this is what we was advocating, and actually if you've got 7 or 8 dose cohorts as we had there, reducing it from day 56 to day 54, that reduces your study duration by 300 days. So this design reduced the study duration by nearly a year just by using an early time point. It did bring in a degree of risk, and actually you still collect day 56 and day 80 data. It's just like you start the next dosing cohort while you're still following up on another dosing cohort, and subsequently you do then collect the day 56 data, and that can be from all the earlier cohorts. But it was a lot of work to try and make this case. For example, we actually had to do an analysis from we was lucky we had some in-house data, and this is it, was trying to predict here, look, day 56 from day 14 data, and we showed we could do that to try and make the case to the study team. And here we went and got hold of 20 individual study data sets to try and make the same case as well. So it wasn't just a case of turning up at study meeting and say, oh, if you use day 14 data, you would actually save 300 days. We had to make a case, and the case actually took a while to do. But also this actually ties into one of my maxims as well, is that you should spend as long designing a study as analysing a study. So here, by spending quite a long time designing this study, we actually save 300 days in this study duration. But often the study design is obviously like squeezed almost into a morning or an afternoon, and then it has massive knock-on consequences into the study. One of my research is the sample size. If you get your sample size wrong, that feeds through into budgets and how long the study will be, how many people you employ to do the study, how many sites you would have. So getting your design wrong, I mean, one of my things is that the 3 most important things in any study are design, design, and design. And that's actually, because if I've got the wrong analysis, you can get another statistician come along to come and reanalyze the data. But if you've got the design wrong, the solutions aren't so straightforward. In fact, one of the things I always say is actually, if you've got to do complicated statistics, you've got your design wrong. So I came here and I was trying to make a case for doing adaptive designs here, and we do a lot of work in ScHARR, emergency medicine. And so I was talking about a study where we had a 2-year primary outcome. The Rat Pack trial was a machine that went ping that helped you diagnose whether someone was having a heart attack in an emergency department setting. The primary outcome here was 4 hours. I've designed an emergency medicine study where the primary outcome was at 20 minutes. So you're almost doing real-time data. You can't get much quicker than that. It's, emergency medicine trials are almost like set up logistically to have adaptive designs. This wasn't an adaptive design Rat Pack. It was done as a fixed sample design, but we was able to retrospectively go back and reimagine it as an adaptive design, and it was analysed by a student of mine, Laura Sutton. And this is actually what you do in an adaptive design. This is called like a random walk, and these are the stopping boundaries. And you can see it would have stopped if we'd have done it as an adaptive design, after 2 interim analyses. And this is just like reimagining the studies. And this is actually the left-hand results is actually the actual trial results. And this is actually what we imagined the study would have looked like. And what we did, we had the data randomization for the people in the study, and we just went and analysed it as they came into the study. And the important number here, and a lot of these things, is, and I'll come over this with pound notes later on, it's actually study duration. It was 12 months quicker. So time is of the essence quite often in these things. So you'd have potentially got an effective treatment available to be used 12 months quicker than if you'd used the fixed design. And that was the motivation in the dose escalation study and things like that. The motivation there was to be as quick as possible while maintaining scientific rigor. You don't want to chuck scientific rigor out the window. You need to be thorough as well in your design. The next study actually just flags up some of the, I was talking about time and I was talking about pound notes. This study illustrates how those two things are not usually related one-on-one. So this was actually another emergency medicine study. It was called ScHARR, and it was an emergency department study. But what we was planning to do was going to have 4 interim analyses, but actually 5 analyses in the study, and we had various scenarios in the study design, and we actually did simulations, and we said, well, if the treatment worked, we'd have stopped after the 3rd interim analysis. If the treatment didn't work, we would have probably also stopped after the 3rd interim analysis. Actually, the treatment not working is actually quite important, because actually getting on for like half of all the treatments that you do a trial of don't actually work. So usually you're not stopping for efficacy, you're stopping often for lack of efficacy. So we was making the case here, and these were the costings for the different looks. So even though these are equally spaced interim analyses, in calendar time, they're not equally spaced, because the speed of recruitment picks up as the study goes on. So these are the costings: 800,000, 1.1 million, 1.3 million, 1.6 million, 1.7 million, according to when we did the interim analysis. In terms of patient time, in terms of calendar time, you can see if you stopped it at the 1st interim analysis, it will save 19 months. But what people always quite surprising is actually, so you stop the study after 25% of the patients, but you've still spent half the money. And that's because there's a lot of infrastructure costs when you set up a study. So so you stop the study after 1 interim, 800,000, and if we'd have gone to the end, 1.7 million. Well, you still have to set up the study, still have to do ethics, still have to report it. So it's more it does save pound notes, but it's more like the time that you save. And obviously you could argue it's more ethical to do a study quickly and get the answers quickly, and stop people being randomized to a treatment that you know does not work, or you can show not to work. But it is actually touches on when you do a sample size, what do you quote? I always say, well, you should do a sample size adaptive design, because it's going to save you money, it's going to save you time. But then the maximum sample size you could have in that study, I said 1800 was the sample size. That was the maximum. If we hadn't done an adaptive design, it'd have been 1500 patients. So if you quote the maximum sample size, I say it's going to save you money. Oh, by the way, it's more expensive and it's longer. And it's like a bit of a contradictory thing. And actually, most people, when the funders of research, the sponsors, they think at a portfolio level. They're funding a lot of studies. They're funding like dozens of studies a year. So they actually want to know how much money they're spending across all their studies. And so if they're getting all the maximum sample sizes, they might fund less research, which is actually undermining the arguments for doing adaptive design, because you're saying it's going to take less patients, do quicker, and save you money. But then The other things, if you use the maximum, that is an issue. And then if you do the expected, there could be a challenges then for the funder, because there is a chance that you'll be bigger than your expected sample size. And that's because you might not stop after 1,100 patients. You might go on beyond then, in which case you've got to go back with your begging bowl and ask for more money to do the study. So the sample size calculation, just from a logistical point of view, is a challenge, and how you communicate that. In that study there, we had like 5 or 6 sample sizes, about 5 or 6 grant costings, and it does make it look a lot more complicated. And what people want to know is one number, one sample size, and they'll give you the check to go and do the study. I actually wrote this in PowerPoint, and I had bullet points which were appearing, but it doesn't work when I've imported it here. There are other type of studies that I've done before. One is a seamless design, and I highlighted POC's study, Fung study, where he was looking at dose range. And what he actually did in that study, it was done in 2 parts. He actually stitched 2 studies together. He did a dose ranging study, then he picked the winner, and then the best dose, he then did a proof of concept study. So he did 2 studies in one, under one protocol. And this is an example here of the midfoot trial where they've looked at a range of treatments for diabetic foot ulcer, then they've picked the best treatment, and then they're going to evaluate that definitively. And that's actually what is called a seamless design. And I'm on the trial steering committee of this study. Another type of adaptive design is called a platform study, where you have one protocol, but under that one protocol, you look at lots and lots of different treatments. And Agile Accord is an example of this. So far, they've evaluated 3 treatments, and so they've got a global protocol. I mean, a lot of the time and effort when you do a study is writing the protocol, setting up all your committees, getting ethics approval, and things like that. So if you can get an agreement to write a master protocol to look at lots of different things, it will save you time and also save you money. So this is Agile Accord. I'm on the data monitoring committee for this. I'm on one data monitoring committee, and it's evaluating all the different protocols. And just to be confusing, this study was in a platform study, and it was a seamless study within a platform study. But this is where time is of the essence, because it's a COVID study, COVID treatments, and they want to rapidly evaluate different COVID treatments in an early phase, and then it saves time for every drug they bring in. They haven't got to do a protocol. They haven't got to set up a data monitoring committee. They get a new ethics approval. It's just quicker to do. It's where they've speeded up the logistics to get quicker decisions. I actually agreed to sit on 2 at the same time. Agile Accord was the publicly funded one, and I agreed to sit on an industry funded one as well. And so the industry funded one sadly didn't start, which was still quite promising. And this is actually funded by the UK government, the Agile Accord one. So you've heard me talk, you think like it's a winner. Why aren't people doing adaptive designs? Why aren't people being more efficient? Why aren't people doing all of these things? And Munya in his PhD went and asked people why they aren't doing adaptive design. It's a no-brainer. If you can do, then you should be doing them. Why aren't you doing them? So he asked academic researchers why they're not doing it. And actually the text might be a bit like small. Actually, in academia, one of the main barriers, we haven't got the money to do it, and the way research is funded in the UK, you only get funding once you start your study. So all the design work is done for free. So you do all the design work for free, and obviously adaptive designs are more complicated. And if there's no funding to do it, there's not much incentive to do it. So that was the #1 reason for academic researchers. Then there's also like lack of knowledge, lack of experience, and various things like that. And so and so people just wanted to get hands on things and see how it's done. What was interesting when we asked industry people, lack of funding wasn't up there. It's actually really down low, but they still had lack of knowledge as a reason for not doing it. People it's actually what I call the legalistic argument of precedent. People they like to get an off-the-shelf design. It's already been done already. We'll apply that one. That's got published in the Lancet, so they know that it's an approved design. But then that presented another challenge, is people wanted examples, but people don't report them very well. So this is like Munya's work again, and he found that adaptive designs work. So if you wanted to get a paper from the Lancet, copy it, see how it's done, they didn't actually report them very well, which is why it was published last year. The Consort guidelines are a series of guidelines for the reporting of clinical trials, and Munya led a group to extend the Consort guidelines to designs. So that would take out one of the concerns for implementation, the lack of good published worked examples that you could apply and bring into your own research, because hopefully everyone's now following this guideline when they do an adaptive design, and you can base your work upon that. So what are the low-hanging fruit? I say, like, everyone should do adaptive design. Group sequential trials are the basic. If you went and read the statistics literature, there's lots of weird and wonderful designs. But the first design I did is actually probably 50, it depends where you're looking at. That's actually the vast majority of trials just do one look at the data. And another one is sample size re-estimation, which is what my PhD student Julie Edwards did, and she actually just this morning responded to, she got minor revisions for her PhD, so she's very well in her PhD. And also the assessment of futility is quite important. I think half of all trials that aren't successful, and actually 55% of trials don't reach their target sample size. They struggle to recruit. So a futility assessment is actually, is it worth continuing with this study? That's what you're saying. Are we seeing an effect? Is it worth spending any more money? And that would actually cut the losses of quite a lot of studies. It will stop a lot of studies continuing, and it will look like we're more successful at actually doing our studies as well. Because it looks like, instead of actually 45% failing to reach recruitment, we actually have 65%. So it'll look, actually our metrics will look better. But stopping good money going after bad, and just actually saying, is the treatment working? Can we stop early? That would actually improve things as well. So future work, I actually touched on future work, what I'm doing. One is, how do you present sample size calculations in a protocol? And I hope to have a PhD student starting in October on looking at this question. It's a logistical question more than a statistical question. There are methods already out there, but what is the number to best present, and what is the most easily understood one? And that's what they'll be working on. And I've got another PhD student starting, will definitely be starting. Assurance as a term is how confident that your treatment will work. And so it's basically looking at, how does your assurance, how is that impacted by doing adaptive decision points? So the work is a growing work, but it's actually still early in adaptive designs in many ways. And so we're at the dawn of quite a lot. It's actually like a few studies have crept through, but I think we're actually at a point where we're going to start seeing lots and lots of adaptive designs. And it's a dawn of some interesting work, because actually it's bringing on lots of methodological work to accompany that. So in summary, obviously to do a successful study, we need to be proficient in the way we design and do studies as well as we can. We like them to be efficient, and obviously being efficient saves time and resources, and even the minor tinkering, doing a little bit of amendment to the study could actually save things and help you. And I would say, if you're not thinking about how to better do your studies and improve their efficiency, I would say like they're suboptimally designed. And I finished, and actually it's changed my little map. But I saw some questions and I didn't actually respond as I was going. I could miss.
That's okay. Yeah, we have had a few questions, Stephen. I think some of them you possibly they were posed earlier and you maybe have addressed them, but I'll just repeat them anyway in case there's anything you want to add. Sue Pierce asks, how do you cost and therefore apply for funding for an adaptive design when you don't know how many participants in advance? And how do you decide between an adaptive design and a pilot main study design? And then she did later on say, study design generally isn't funded. How do you get resources to spend a lot of time on this part?
Well, Sue, that's actually, the first question is actually why I wanted to have a PhD student to look at that. And because at the moment we tend to put the maximum sample size in, which is actually misleading, and we want to try and improve that. With respect to pilot main study design, that's why people have started to become seamless as well. They're trying to merge pilots and main studies into one study. And I could talk about the different ways you can do that, but that's actually why people want to do seamless designs, although you can still do them separately. But the communication of the budget is one of the main challenges in doing an adaptive designs. Yes, and your thing is, why do you do this? I would say, like, if I was a dean of ScHARR, I would tell me not to do adaptive designs. It takes a lot longer to design them, and the amount of time I spend designing them, I could do 4 simple studies. And it's something we keep communicating up, because the funders want us to do adaptive designs because it saves them money, but they don't fund you to work on the study design. And if you look to industry, in industry they do a lot more adaptive designs, and funding is not an issue. So they'll spend 2 years designing a study because they'll know the phase 3 study is about to start in like 2024, because they're doing the phase 2 studies beforehand and stuff. So it wasn't flagged as an issue. It is an issue, and it's probably one of the reasons why it is flagged as a reason why people don't do adaptive design, because there's no funding to do it. But the flip of that is why Munya wanted to better report the adaptive designs, because then if you've got a suite of well understood simple designs, people could just start applying those simple adaptive designs. So I don't really know about mental health services. I mean, so anywhere basically, I mean, adaptive design is a broad church, and it could be something really, really simple that you adapt. It doesn't have to be a really, really clever design. For example, you could just say, is this working? That's just a futility assessment. Have an early look. Also, you can actually, like sample size re-estimation, I did a study a while ago, and we was designing a study, and it was based on 7 people. We was doing the study in severe cases because the treatment had not been evaluated in severe cases, and we had 7 people was basing the study design on. And that's where we did a sample size re-estimation, which is quite a simple thing to do. We collected halfway through the study, we just re-estimated the variance and the response rates, and that is a form of adaptation. So yeah, so you don't have to be complicated anyway with mental health services and adaptive designs. Mike, the meta-analysis, has that been published? I'll have to double check. No, it hasn't. I've been pushing Fung to. He wrote one paper, but I'll actually double check. His name was Feng Liu, Fengliue, and his PhD will be in the White Rose repository. I don't know. He'd have put a 2-year timestamp on it because he would have wanted to write that up as a paper. But if he hasn't written it up as a paper, it will soon become available on the White Rose because it was in his PhD. It was a lot of work to do that, to make the case to do an adaptive design. Oh, I should have used prescient. Thank you, Amanda. I was trying to think of audience. So has anyone else got any more questions? Have I been through all the commented ones?
I think there's one from Yvonne that's just popped up. She says, do you think researchers in low-income countries could benefit from such designs?
I think they could. I mean, it's the same principles. It's like the same principles. Adaptive designs just work generally. And what I point out is the logistics, not the statistics. So if logistically, like when I was mapping out the adaptive designs, if you can do it and you've got an early time point and you can collect the data and you can get it to the analysis center in a timely manner, and the time point your endpoint you're collecting is clinically meaningful and you can make decisions, then a statistician will come up with a design to solve it. So if in that saying if logistically you can do that, then you can do it in any setting really, and it's more the clinical scientist that will help you that. So I've talked to Tom. Adaptive designs do happen in a regulatory setting. There are simple adaptive designs and not simple adaptive designs, and they see more of the simple ones because they're more commonly used. But if you're going to do a more complicated design, you do have to talk to them. And ethics isn't a barrier. In fact, you could argue an adaptive design, if you've done it right, is more ethical because you get your answers quicker. Or if you're not getting them quicker and might even be slower, at least you're more confident that you'll get those answers. So the thing, sponsors, I mean, the sponsors should, actually most ethics committees and most sponsors will have a statistician on the panel. And so when you go to a sponsor, the person who actually agreed to fund you, or on the ethics committee who are adjudicating it, there should be a statistician there. And if there's not a statistician on the panel, they will often call in the expertise to do the review, especially if it's a very complicated design. And ICH, I can't remember what it says. I mean, it's probably precursors adapted. I think it does mention about sample size re-estimation. But the main thing is, I think ICH is just the principle of making sure you're not making a type 1 error and making judgments on that. But the regulatory guide, because actually there is such a big suite, the guidelines are a little behind in lots of ways. I was reading through all the questions. Maybe I should have, did I say what people were asking? I hope I did, Claire. I was reading the danger I'm reading the comments, but when I was going to see the comments, I was trying to read the comments and go as I went. ICH E20 is the proposal. Look forward to reading that one, Wang. So I assume ICH E20 is on adaptive designs. But also there are things like Munya Dimaro with his consort guideline. That was to improve transparency as well, and to get things published and better written.
Okay, I think that's all of the questions, and we are coming to the end now. So thanks everyone for joining us today, and thanks very much, Stephen,